Hello and welcome to our Fighting for the Soul of General Practice in Conversation podcast series. On today's show, my co-hosts are, as always, Drs. Rupal Shah and Jens Foell, authors of Intellect's Fighting for the Soul of General Practice, The Algorithm Will See You Now. And we're very excited that today we'll be joined by Ibrar Hussain of Vanguard Consulting. So Ibby, welcome to the podcast. It's great to have you on and thank you very much for your time.
You're most welcome, James. It's great to be here. Thank you.
Well, let's just start by maybe just introducing who you are. If you could just explain to our listeners sort of who you are, what your role is, and maybe just tell us how that relates to maybe general practice.
No problem. So Ibrar Hussain, Ibrar, but Ibrar for short. I've been working with Vanguard Consulting for the last 35 years. And as an organization, we kind of started off life as a firm of occupational psychologists. And effectively, what we've been doing is working with organizations to help them understand and improve performance. And we do that in a particular way through this thing called the Vanguard method, which is a proprietary framework of method of how to move people from the current way of running their organization to a different way. And that's kind of what we specialize in, and that's what I've been doing. At a personal level, I also started out life as an engineer. So I worked with Jaguar and then Ford and went off and did a master's, and then after the master's joined Vanguard.
Well, thank you very much for that introduction. And it's really great to have someone with expertise outside of the medical profession as well here to join us with these clinicians. But I would like to talk a bit about that in the context of today's theme, which is around regulation and regulation within the NHS and within healthcare. So maybe I could just start off with a bit of a broader question, especially in regards to kind of your manifesto and the kind of Vanguard method and the concepts that you sort of teach and utilize. Where do you kind of stand on regulation, and do you see there being some key problems there, and what are those problems, especially in the context of healthcare and general practice?
Yeah, I mean, I think there would be no one that would say regulation is not important. I think it's fundamental, but we have to kind of start with what is the purpose? Why do we have regulation in the first place? Before I go to regulation, I want to just introduce this framework that we think is really helpful. So it's a bit of theory to bring this to life. So in all organizations, there's a systemic relationship between purpose, why the hell do we exist, why are we here, and if we are clear about our purpose, and then we have measures that help us understand how and how well we're delivering against purpose, we are then able to experiment with a method to better achieve purpose. So that systemic relationship exists in any system. Now, the problem is how that relationship manifests itself. One of the problems that we have is that if, unfortunately, you don't start with an effective statement of purpose, and what I mean by effective is our starting point from a Vanguard method point of view is always to look at any system, any organization from what we call an outside in as a system point of view. So when you walk into any organization, any system, so if it was, for your case, GP, health, well-being systems, you ask the question, what is this system here to do? And in order to anchor that, you sort of say, without whom would it not exist? That then ensures that we don't get conflation in terms of whom are we here to serve. So we need to understand what we're here to do. And if we understand that, and that's anchored in the people we're here to serve, be they customers, be they patients, be they service users, we can then ask, if that's why we're here from those people's points of view, what measures will tell us how and how well we're working against purpose? That then gives us an anchorage that then allows us to experiment with what we do and how we do it to better achieve purpose. Invariably, what happens in organizations is that's not where this relationship starts. It typically starts with an imposition. And often what happens with regulation is it is imposed. And because it is imposed, I want to stay away from regulation just for the example. So let's go to a simple example of a call center.
Mm-hmm.
So if we take a simple call center, service center that is there to provide service or value to the customers that use it, you kind of ask the question, typically, how are those sorts of organizations run conventionally? And it may surprise you, it may not, but typically the way those organizations are run is our job is to effectively ensure the phone is picked up, because the assumption is that is important to the customer. So what we'll then do is, in order to ensure people are focused on that, we will measure things like grade of service. Grade of service equals how quickly do I pick up the phone? So that would be, for example, 80% of calls picked up in 20 seconds or 5 rings. We may choose to measure how many calls an agent takes. We may choose to measure how long they spend on the phone, because all of those things are the things that, if I as a leader am running that sort of system, those are the sorts of measures that I'm interested in. They tell me how well I'm doing what I'm here to do, which is pick up the phone, answer the customer's problems, deal with their queries, etc., etc. Now, if we impose those measures in that system, we unfortunately create a de facto purpose, an unintended but actual purpose, which becomes hit the number, hit the target. And rather than liberating method to better achieve purpose, that starts to constrain method. So I would say regulation is important, but what's important is, what is it seeking to do? What is the purpose of regulation?
Okay, that's fascinating insight, Ibby. Thank you very much. I just at this point would like to just intercede quickly and just bring in Ru. Ru, I know that you've probably got a burning question on this topic.
Yeah, no, it's really interesting to hear you, Ibby. I think that the purpose of us as GPs hasn't really been elucidated. So I think that you could argue, and I think politicians and maybe the public would say, well, the purpose is to make people live as long as possible and to refer dangerous illness and to minimize risk. And I don't disagree with those as premises, but the kind of upshot, the corollary has been that the way that the targets are kind of about the numbers. And so I just wonder if we need to be clearer, to have a clearer understanding in the profession and with the public about what we are here to do, because there's a huge emphasis on trying to minimize risk, which we've talked about in other podcasts as well, and maybe to make people live as long as possible, bearing in mind no one can live forever. But then all the kind of side effects of these referrals and this way of doing things isn't taken into account. I mean, I've got 2 examples from today, which I don't know if it's worth, I could mention them. There's, for example, in clinic today, 84-year-old woman, she came to see me and she's really unhappy for various reasons. Her living arrangements are pretty awful. She's very stressed by them. She's very unhappy where she is, and there's all kinds of problems with it. But for me, the way I measured is, why aren't I getting her diabetes under control and her blood pressure? So both of those are not to target. And that was the reason why she's called in to see me. So the purpose, you could suggest, well, having poorly controlled sugar and high blood pressure is terrible. And maybe my main job is to try and address that. But the thing is, she'll say the reason why all of this has gone haywire is because I'm so unhappy and stressed. And so the kind of right thing to do for her is to really focus. I think if she could be rehoused, then the other stuff would get better. But that's not how I'm measured. So I don't know if that ties in with what you're saying.
It absolutely does.
To add on this, because there are certain assumptions in there, and our job as GPs is at the same time be there for individuals and treat them as individuals, and we have to say it's patient-centered, but on the other hand, of course, it's not. We are treating populations, and the individuals are averages of our population averages, and that's how we are measured. And the main modality is giving medication. So Ru and I are not measured. How are we achieving this goal with imagination, social interventions, this and that? It is you have to offer this tablet or that tablet, and we see that all the time. And that's often a moral moment. Do I do something which I'm getting paid for, which might not be in the interest of the individual? Or is it something where I have to balance and say, well, I put you on this register. It comes as a package deal with invitations, participating in surveillance medicine, and the client to pay for this service is the health board, not the individual. So it's a lot of morality, a lot of moral moments in something very mundane every day, 10,000 times.
I just came back from having a cup of tea with my mum, who's 84. And so she's got a mild anemia and a slightly inflamed liver. But what the GP wouldn't know about her, because it's never the same GP, this old trope, who sees her, is that she really doesn't like doctors. I mean, she likes me, but she doesn't like being involved in healthcare.
Yeah.
And it really stresses her out. So now she's on a 2-week pathway. She wouldn't accept any treatment, and it is all kind of a lot of stress, but it's something also to do with purpose. Sorry, I don't want to digress and kind of bring this into the personal. It's just that when you were talking maybe about purpose and regulation needing to be kind of connected with that, what does one make of these kind of situations?
Yeah, I think for us, having solid anchorage is fundamental. And therefore, this notion of clarity of why the hell do we exist and what the hell are we here for, i.e. purpose, is fundamental. I think for me, there's another bit that I'd like to talk about, and then I'll come back to address some of the things that you've talked about and expand on those, if you don't mind. But for me, there's another relationship that is fundamental, which is all organizations are concerned with performance. And when I talk about performance, I mean service, efficiency, revenue, morale, all four of those things. In any organization, the performance is the way that it is because of the system. And when I talk about system, I don't mean IT system, I mean the way we design and manage work. And the system is the way that it is because of how we think. And in particular, how management and leadership think. And it's how leaders think about three things. It's how they think about the work, those who do the work, and the way the work should be done. Because of how we think about those three things, that's what drives us to create a system which allows performance to happen. So if I live in a world where I think, right, the only way that I'm going to be able to deliver effective health and social care is by actually specifying and procuring it. That's the world that I live in. Then I'm going to create a system that's based on that fundamental principle, if you like. If I do that, and for me, that's what the current system does. The current system is all about optimizing health and social care. It's all about delivering value for money. It's all about delivering safety. It's all about optimizing the current methods we have for how we specify and how we procure. That was the whole point of creating this public-private partnership, this marketplace where commissioners have the ability to choose and so on and so forth, which at a personal level, I believe is all fundamentally flawed. But having started there, the consequences, I would say, having studied these systems and I'm talking now about the broader well-being system, what it leaves us to is the current narrative everybody's heard, but I'll repeat it. Demand is rising, and demand is rising because people are getting older. We're getting better at looking after people, therefore they're living longer. And because they're living longer, they're getting more comorbidities, and as a consequence of all of that, the demand is rising. Well, I'm really sorry, but I fundamentally disagree. That is not the case. What I would say is that actually, when you look at what I would describe as the value demand, hello, I need help, that is broadly stable. But we have a preoccupation with budgeting, with managing our finite resources. So what we do is we start to do things to manage demand. And the things that we do to manage demand are things like quotas, things like rationing, things like gatekeeping, things like prioritization, things like threshold. So they're kind of filters to get you in. And then we do things like, actually, let's signpost people. You know, where are people best served? Well, they're not served in the GP practice. They're not best served in the community practice. They're not best served in the hospital. They're not best served here. So these things we'll put here. These things we'll put here. So we functionalize and fragment these services that are meant to help people. And our whole focus on the demand management side is stop them getting in. And the consequence is that they get bounced back. But guess what? The fundamental problem they have has not been solved. So it only gets progressively worse. So when they do come in, effectively, they cost us more and it takes longer.
I would like to bring in a colleague of mine called Dr. Singh, who found out, Ibi, that this is actually the case. We GPs, we are fearful of patients that if we keep the doors open, everything they want is wanting to see a GP. They really want us there, and we are flooded with value.
Yes, that's the assumption.
What he found out is that's actually not the case. Demand is predictable and stable, and clinicians' fear is high, and the fear that you are left alone and you cannot manage the demand is also very high. And in their practice, they didn't cap the amount of, they didn't close the doors, they don't put the drawbridge up. They say, yes, come in. And our problem is only to have enough people, because we know when you're coming in. Monday morning, everybody thinks, oh, I need to see a GP. Very predictable rush hour patterns. Also predictable if there's a strep A outbreak, or if everybody thinks I have ADHD and I need to get it validated. A lot of these drivers are predictable. The way we adapt to it is the problem. And as you say, once you say, oh, we have a pharmacy first service, and we have an urgent care center, and we have a rapid diagnosis clinic, and all these little bits that support the GP by taking the GP work away, then it becomes very complicated. To add on this, if you have NHS 111 or urgent care as a parallel system with pathways for everything, that leads clinicians to game and to control their performance parameters at the expense of the patient.
Yes. I mean, for me, I've worked with a number of GP practices, and one of my frequent questions is, you know, how often are you as a practice sending people to programs? And the answer is quite often. So be it weight loss, be it diabetes, be it mobility, be it whatever it may be, there are programs that have been commissioned and are available for us to, you know, point our patients and service users to. And we keep doing it. And the question I ask is, cool, excellent. How well do they work? Pardon? Is typically the answer. We don't know. You know, what annoys me, and it's beyond annoys me, it makes me bloody angry, is, you know, we talk about evidence-based medicine. And I'm asking the question, okay, if we go back to this notion of purpose, measures, method, purpose, help someone get control of their diabetes, right? Measure, the diabetes becomes stable and hopefully comes down. Yeah, dead easy. Method, we refer them to whatever program. Okay, well, 3 months later, 6 months later, what data do we have that says Ibby's diabetes is now better controlled and went down? How often does that happen? And because we don't close the loop, how do we know what works? How do we then as clinicians know what to do more of or less of? Now, what regulation currently drives us to do is comply. All it is measuring is compliance against an arbitrary set of things. No one is seeking to understand and improve.
I think in some ways regulation prevents us from kind of thinking about what the purpose is in each particular interaction. So, you know, what you say, Ibby, you know, with diabetes, that's in a way, it's rarely like that my only purpose in the consultation, I know that's not what you were getting at quite, but is to definitely bring down the sugar levels. That's part of the purpose, but there's sort of multi-pronged purposes in the consultation, probably. And so some of it is about complexity of life and kind of other stuff that's going on, and how, you know, in this world of regulation, I think it discourages clinicians from thinking about that, thinking about carefully, what is the purpose? What is my purpose in this consultation? What am I trying to do here?
Well, what I think what the regulation does is it drives us down, as Jen said, pathways, protocols, unintended consequences. It diminishes our ability to look at the whole. That, I think, is a fundamental problem.
I think it also invites a culture of fear, because, you know, you're watched and you preempt that there's somebody wanting to find something out that is not great, which blends in with our perfectionism and possibly finding the wrong, performing under the wrong person's gaze, because under the watchdog's gaze and not for the gaze of the one you serve. And that's a real dilemma.
Yeah, well, you see, the whole purpose is almost conflated into one of enforcement. It's effectively, we are being policed.
We are used to that. We cannot even think
as opposed
not
to. And I think what, therefore, for us, the manifesto is all about opening our world up to say, no, this is an opportunity to draw a line in the sand and actually say, what should the purpose be? The purpose should be regulation is there to enable us and encourage us to understand and improve. In order to do that, if we take that systemic relationship of purpose, measures, method, it says what the regulation should be about is, rather than specifying measures and method, actually encourage organizations to actually be clear about their reason for being from an outside-in point of view. Make them responsible for having measures that help them demonstrate how and how well they're delivering what matters to the people they're there to serve. If you can get those two things, not specify how, not specify what, but actually say that's the guideline. So when we turn up, we're going to seek to understand whether you're clear on your purpose and whether you've got measures that help you understand how and how well you're delivering what matters.
I wonder what system of regulation would you implement for this woman in her 80s I mentioned at the beginning, who, yes, her blood sugar control has declined, deteriorated, and so has her blood pressure control. But, you know, the fundamental problem that she really wants to talk to me about is the stress involved in her particular living circumstances. And so, you know, how does one measure whether I do a good job with that or not?
Well, for me, you see, you know, if we say our reason for being has to be understood from the point of view of the people we're here to serve, for me, in that particular scenario, the question I would be asking is, what is your contribution to help that woman achieve betterment from her point of view?
It's a really, like, even you just asking that question, it's a difficult question and a challenging one. And it's one that I want to be asked. And I think if we were asked these questions, if we asked ourselves these questions, it would really drive up the quality of our practice. But there has to be quite a lot of trust implicit in that case, because we might be having these conversations, but actually evidencing all of this is quite difficult, and it would also be very cumbersome.
And you see, to me, when I'm having these dialogues with people that I'm working with, you know, the framing that we end up with is something like, well, actually, if we think about people, there are kind of, broadly speaking, three broad states that require me to ask for help. One is one may be where I'm not well, so the immediate outcome is maintain my well-being. So that's what stability looks like. So you know, I was living my life, I was doing all the things that I wanted to do, and something's happened that's now affecting my ability to live my life the way that I want. I now need your help, and your help, good, looks like I'm now able to live my life how I want to. Another may be where there are only two certainties in life, birth and death. So I'm at a stage of my life where death is coming. But what I want to do, and what's important to me, is that I die a good death. I don't know what that looks like, but I probably know what it doesn't look like. And it's about you and I engaging in a dialogue that allows you and I to work together for you to enable me to die well.
Ibi, I would like to be your servant on your trajectory to die well. I really would like to, but I'm casted to discipline you. I'm not your servant. I'm your rationer. I'm your discipliner, and I'm disciplined in disciplining you. You say to me, you want to live the life you want to live, but I've got news for you. You shouldn't live the life you live. You should exercise more, drink less. I keep a tab on this. You should engage regularly with my surveillance regime. I get punished if I don't punish you. So
Yes.
we're both in a system. And then when it comes to your good death, you might think it's a good death, but if I haven't captured data about you, acted
Yes.
on them, the medical examiners will scrutinize me.
Yes.
Because
Yes.
you need to have really good paperwork when you
Yes.
are
Yes.
you're heading across river
Yes.
Styx.
Yes, and that's such a beautiful articulation, Jens, of the problem here in terms of how the current system is actually diametrically opposed. I don't think anyone set out to say we do not want to help people to live a good life and die a good death, but that is the bloody consequence. We are stopping people from living a good life and dying a good death.
Yes, that's what we are casted for. That's our mission. You should live as long as possible, a medicalized life and a medicalized death. What's your problem?
Do we have any solutions? Do we have any thoughts on how we can better implement these changes?
Well, you see, I think the issue is that right now, the only way that we can conceive of solving this problem is by changing the system. At the moment, everything that I've seen in the last 30 years, what we've done is our assumption has been, in my view, incorrectly, the underlying core system is fine. But there's always room for improvement. So what we need to do is do what we do better. So we tweak, we refine, we pull this lever slightly, push that lever slightly, and as governments change and regimes change, as Jens alluded to previously, what happens is that we tweak and assume and call it reform and give it different labels. But what I would say is the underlying system has not changed. And what we have to do is change the system and design the system to actually achieve what we would all regard as a better purpose that's grounded in knowledge of what actually matters to the people we're here to serve.
And it requires such a change in culture, Ibby, because we don't ask those questions. You know, I know that we're meant to ask people what matters to you, but we don't do it in the right way, or not in the the right depth, because it's very difficult and not kind of culturally acceptable in a way to ask those questions. I could refer you, but it'll probably mean that you spend several days in hospital having various investigations, and each investigation might come up with some other problems, and you'll probably be recommended several medications. Is this what you want? It might be, but is it what you want? You know, you were talking in the first instance of, I want to get back to living my life how I want to live it. That's not how it's framed. You know, when someone comes to see me, I don't talk about it in terms of function. I talk about it in terms of numbers. So changing culture so that it's acceptable for the public as well as for clinicians. I mean, how do you do that?
Well, how you do that is by actually doing it. Now, often what happens is we come up with a great idea. We may or may not run a pilot or a series of pilots, but we get to a place where we've got this thing that we have tried and tested, and we think it's great. How do we engage everybody in it? Typically, we roll it out. Now, let's assume, because I don't want to argue about the particular example here, but let's assume that what we actually had was a great thing. It actually did do the right thing from a customer's point of view, and it was arrived at in the right way. When we roll that out, unfortunately, we kill it. Does that make sense?
I see it all the time, because you get always these policy things, and in Dorset, blah, 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 worked really well, whereas an enthusiastic GP and a community activist, and everybody is happy. And then you think, well, yeah, it's like a franchise. It's like we have a new burger on the menu and we are health McDonald's, and now it should be everywhere because we are franchising it. And that makes it very, very difficult.
And that's further reinforced by, you know, our mindset that says benchmarking, best practice are good things to do.
Yeah.
I'm really sorry they are not, because they assume that there is no variation.
There should not be any variation, because we have to reduce unwarranted variation in healthcare, postcode lottery. That's really bad.
But we might want that as a goal or an intention, but to start with an assumption that says there is no variation is really dumb.
Yes.
Because we know there is variation. Health is a demographic system by design.
So Ibby, you know, so if, for example, in our practice, if we were able to effect that kind of culture change probably through lots of conversations with the clinicians getting people on board and starting to think in that way. I mean, I think how you do it is to change the way we talk to each other in practice meetings, what we talk about. And, slowly we might be able to get somewhere towards where we, you were
No.
suggesting.
Slightly different. So this is what I would call, so typically the way we do things, and this is where rollout kind of starts to become crystallized, is typically what happens is that we do things, we go on courses, we learn new tactics and methods. And as we do that, we add them to our armory. Now, what I would say is right now, when we talk about understanding and improving performance, today, everything we have in our armory is wrong. So this is not an add to thing. This is a give up and replace thing.
How does one do that with the current system of regulation?
So the way you do that is you say, okay, cool. At the end of the day, we're here to serve patients, right? I want to do the right thing. My colleagues want to do the right thing. We have to start somewhere. So let's start with the next person that walks through the door. The next person that walks through the door, what we do is we create the space to allow them to actually articulate what's important to them, and we seek to service that pull. In doing so, there are some principles that become sacrosanct. The first is, what we're going to seek to do is we're going to seek to allow that person to define the boundary of the system. The boundary of the system might just be practice nurse and them. It might be practice nurse, GP, and them. It might be GP, district nurse, and them, depending on their context, their situation. Does that make sense?
Say a bit more.
So if, for example, I'm someone that needs support at home in some way, shape, or form, then whatever happens in the GP practice cannot be divorced from the support that I get at home. Both of those two things have to be stitched together in order to work seamlessly.
Yeah.
Because if I'm turning up in your home and I'm a clinician, label nurse, doing XYZ, and you turn up in a GP practice and GP clinician number 2 does XYZ, those two things need to have a common and shared understanding and a common and shared outcome. My betterment. So if we decide to do that, principle 1 is that person sets the boundary. Their context, their situation sets the boundary. The second thing is we as a practice, we as a system will seek to operationalize as far as possible seamlessness, which means continuity for the person. That does not mean I see the same person every time. What it means is what I experience from the system is me not having to repeat. The current system is designed typically to be transactional and episodic. And therefore, I get lost in that transactional and episodic view. We need to break that cycle. When you have worked to those two principles, the consequence is you unlock so much. And it doesn't take many cases to start to unlock. When we did this with a consortium of GP practices, we started with one practice and then we rolled in. What that means is that when you arrive at a better way of doing something, you don't just say, here's the blueprint, now everybody go do that, because it's the process by which you get to that better way that is the thing that gives you the sustainability. So we need to allow everybody the opportunity to learn how to learn, unlearn for themselves.
I really, really like it. I like the idea of unlearning and learn how to learn and favoring local processes rather than having yet another failed attempt to discipline everybody. That fits in with me. I'm probably a born anarchist. But on the other hand, I'm also a fearful street level bureaucrat. I don't trust myself. I don't trust my colleagues. I don't trust anybody, and think if we are let loose without any surveillance, will we not do bad things? How can I avoid this to happen? How can this organization be virtuous?
Hence, what's important is this isn't about anarchy. This is about good anchorage, which is purpose in customer terms.
Yeah.
Measures that actually help you understand how well you are delivering that purpose. And then you get latitude and freedom to experiment with methods to better achieve purpose. And what allows you the assurity of, am I going off track, on track? How am I doing comparing relative to others is the measures.
Yeah.
And it's not a competition. We are all here because there are people out there we're serving. How can we work better together to help them live the life that they want, die the death that they want?
Ru, what about you? How does this line up with your vision and your thoughts?
Be very attractive to have locally set regulation that encourages us to sort of answer those difficult questions, like what are you doing for the betterment of this particular patient cohort? Let's think about it. And I think it would be really difficult to standardize that across the whole country. So I suppose I'm kind of thinking how this would work practically. I mean, I think
what you're standardizing, Ru, is, if you want to standardize anything, is the approach. But what you're not doing is specifying how people do it.
Yeah, I like that.
That gives people autonomy, but and then the focus of the regulator is they are there to help, not chastise, not discipline, not special measure. They're there to help you understand and improve.
It makes a lot of sense to me too. Let's hope we can achieve it.
Well, on that note, I think that's a lovely point for us to kind of round things out. I imagine we're going to receive quite a lot of questions and quite a lot of comment on the topics raised today. It's been fascinating, and I think we've managed to cover quite a lot of ground with a few broad strokes, a few broad questions. We've managed to drill down quite a bit there, I think. So, Ibi, thank you so much for your time and for joining us on the In Conversation podcast today. Ru and Jens, it's always a pleasure to have you joining me asking the questions as well. And I'd just like to say, if anyone's interested in finding out a little bit more, I would go and check out Vanguard online. You can just do a little Google search and you can find the work that they've been doing, and there's a lot of interesting resources there. And of course, Fighting for the Soul of General Practice, The Algorithm Will See You Now, is available from all good bookstores and from intellectbooks.com. Big thank you to Ru and Jens again for joining me today. And Ibi, it's been such a pleasure. Thank you for your time and for all this insightful comments.
Thank you, Ibi. Thank you, James. Thank you, Ru.
Thank you so much, everyone.
Thank you very much for the opportunity. And I love you, Jens. I love you, Ru. I love your work. I love your book. Power to you. And if there's anything we can do to help, you know where we are.